we are going to discuss about the post-COVID syndromes. So I'll be mainly focusing about the pulmonary syndromes. And these are my disclosures. First of all, I'd like to discuss about the epidemiological model that has been put forward by one of the senior epidemiologists in America about the COVID. As you can see here, currently we are facing this acute pandemic of COVID pneumonias. And with time, of course, with the introduction of the vaccination and other strategies, that will go down. But hence, we are facing another breakthrough or pandemic of pulmonary fibrosis, as you can see here. Basically, I mean, you are aware about 95% of the people will either have mild to moderate symptoms or no symptoms, but 5% will develop severe or critical symptoms. Among these 5%, we are aware that at least 20% will come to disease, and about 30% will fully recover. But again, the main worry is that nearly 30 to 50% will develop what you call this pulmonary fibrosis or post-COVID lung disease. That is a significant amount that we are going to face, and there will be quite a lot of patients with us who are on oxygen and who are on various treatments and who are breathless, who can't do their daily practice. It will be another pandemic that we are globally. So this is being introduced by Dr. Udavadia. He's one of the respiratory specialists in India. He published this article in Lung India, and he's talking post-COVID pulmonary fibrosis as a tsunami that comes after the this earthquake of COVID pneumonia. So we have to prepare for this tsunami. These are my objectives. Initially, I'll be discussing about COVID and lung injury. Then I'll be discussing about the post-COVID pulmonary syndromes, as well as I'll be mainly focusing about this post-COVID lung fibrosis or post-COVID interstitial lung disease. We have to understand this COVID and lung injury, this concept very well, because this is the time that we are creating patients with lung fibrosis. So unfortunately, there are two hits that our lung is or our body is faced with a COVID. The first hit is the epithelial or alveolar injury, and the second hit is endothelial injury. Epithelial injury, I mean, as you're aware, when the SARS coronavirus 2 is exposed to our respiratory epithelium, it is subjected to ACE2 receptors in our epithelium, and then there's a cascade of inflammation, predominantly driven by the T lymphocytes as well as the macrophages, which will result in a hyperinflammatory syndrome. This hyperinflammatory syndrome is one of the classical hyperinflammatory syndrome that we have never seen during our lifetime. This Budingan group from America, they have studied about this hyperinflammatory syndrome, and they have compared it with influenza pneumonia. For example, the patients who are infected with influenza, they'll get a peak of cytokine storm, and then it will resolve within a few days to weeks, and it will come to the baseline. But unfortunately, the patients with SARS coronavirus 2 pneumonia or COVID pneumonia, what we can see is actually it leads to a delayed immune response, and then that response will persist for longer time, sometimes days to weeks, and sometimes we see for months even. And in this study, again, they have identified the cumulative cytokine exposure in a patient with influenza pneumonia compared to the COVID pneumonia. As you can see, the amount of cytokines that they are going to expose during this COVID pneumonia is at least threefold when compared to that of influenza pneumonia. So we are going to face a very new as well as a significant pneumonia, which we have never seen before. And this secondary injury is caused by this hyperinflammation or this immune response. I'm sure you're all aware of this staging of this COVID-19. This is the stage 1 of the COVID-19 disease is the early infection where there's a viremic response or viremic phase. It lasts for about 5 to 7 days. And then there's when the virus load is going down, the patient starts the inflammatory response during the phase 2, which lasts for about 7 days to 14 days. That is the pulmonary phase where the patient's developing breathlessness as well as hypoxia. And when they go to the stage 3, that is the hyperinflammatory phase, where the patients develop organ failures, acute respiratory distress syndromes, circulatory shock, cardiac failure, and systemic inflammatory response syndrome. And all these things are driven by the inflammatory response. And at that point, the viral load is significantly low. Therefore, if I summarize, the epithelial injury that is caused by COVID-19, there's significant evidence that there's a prolonged exposure to cytokines and there's a prolonged hyperinflammation, which is leading to epithelial or alveolar injury, which leads to structural damage. But unfortunately, we as clinicians, we also helping this epithelial injury basically by 2 ways. The first is the nosocomial infections, hospital-acquired infections. I'm sure most of these COVID pneumonia patients at the initial stage, they receive quite a lot of antibiotics and quite a lot of high-end antibiotics, which usually are going to affect negatively because it will introduce multi-organ resistant organisms once the patient is staying with us for longer time in a hospital. So therefore, as clinicians, we should avoid early introduction of antibiotics as well as early introduction of steroids. I think that is, we are doing more harm by introducing early steroids when the patients are not hypoxic and not at the pulmonary phase. Secondly, by inappropriate ventilation, and we are introducing the ventilator-induced lung injury as well as self-inflicted lung injury by them. Also, we are introducing epithelial injury and structural damage. So remember, a significant proportion this hyperinflammation is causing epithelial and alveolar damage, but we as clinicians are introducing or contributing to this epithelial injury by introducing nosocomial infections, by inappropriate antibiotic prescribing as inappropriate immunosuppression and immunomodulators, as well as inappropriate ventilatory strategies. So there is a patient, a 44-year-old patient who has presented with COVID pneumonia and he's having post-COVID lung. As you can see, there are areas of traction bronchiectasis as well as ground glass and interlobule and interlobule sepal thickening, evidence of dense fibrosis as well as pleural fibrosis as well. So every aspect of the lung is fibrous on this patient because of this inflammatory response. The second most unique injury that COVID causing, in fact, this has been never reported before with other viral pneumonias, that is the endothelial injury. So I must kind of thank this Ackerman and group from America, where they have studied this pulmonary vascular endotheliitis, thrombosis, and angiogenesis in COVID-19, which is published in 2020 in New England Journal of Medicine, where they have enlightened us about the uniqueness of this virus, right? How it affects the vascular endothelium. And this is the post-mortem analysis, and this they had a control arm of patients who died from viral pneumonias other than COVID-19, and then they had another aspect of patients who died from COVID pneumonia. So these are patients who died from COVID pneumonia. As you can see here, there is microthrombosis in this slide, as you can see in the pulmonary vasculature, multiple microthrombosis. This is one of the pathological phenomena that we see in COVID-19. Again, this is electron microscopic view of the capillary endothelium. You can see this is a normal person who normal control, and this is actually a patient who had COVID pneumonia. As you can see, there's destruction of the vascular endothelium. Here you can see the sprouting of new vessels, which you see in COVID pneumonia. So these are, again, they have evaluated the cumulative angiogenesis. They have compared in a patient with COVID-19 with that of other viral pneumonias, as well as patients who had interstitial lung disease due to other causes. Especially they have taken patient with NSIP. So as you can see here, they have significant amount of new vessel formation or angiogenesis compared to that of other viral pneumonias, as well as compared to patients with other interstitial lung diseases. So if I summarize, again, the endothelial injury that we see in patients with pulmonary COVID pneumonia as pulmonary endotheliitis, and there is thrombosis and angiogenesis, which leads to breakdown of the alveolar barrier, as well as it leads to a non-cardiogenic pulmonary. These two mechanisms are involved in lung damage, not only the lung damage, almost other organ damages. Here again, we as clinicians, we also introduce our part for this alveolar breakdown or breakdown of these capillary membranes. So that is the main reason. Main iatrogenic factor is dehydration. So therefore, it's very important once you are managing a patient with COVID pneumonia, you have to avoid dehydration at any cost. We see quite commonly the patients are significantly dehydrated when they come to our setting to the ICUs or high dependency units, because that dehydration promotes microvascular thrombosis. So there is a patient with this significant breathlessness, and the CT shows non-cardiogenic pulmonary edema. As you can see here, there's increased amount of ground glass in the lung bases in the dependent areas as well as in the peripheral regions. So epithelial damage and unique endothelial damage, which leads to recovery in some patients, but about 20% will die, but 30 to 50% of the patients will develop post-COVID pulmonary syndrome because of these two mechanisms or two hit hypothesis. CDC has been recognized that at least 1 in 11 patients again readmitted to the same hospital within 2 months who have been discharged with COVID pneumonia. So that led to further evaluation of these post-COVID syndromes. So how to define a post-COVID syndrome? So this actually is an excellent paper published in Nature Reviews, and they have discussing about the viremic load as well as the symptoms and the post-COVID syndrome. Usually we define the acute COVID phase from day 0 of symptom onset to the 28 days or 4 weeks. And after 4 weeks, if the patients are having persistent symptoms, actually we consider as post-COVID, and that is also further divided into acute or subacute post-COVID, that is from 4 weeks to 12 weeks, and from 12 weeks to 6 months is considered as chronic or post-COVID, and then 6 months onward, we consider as persistent COVID. So it can affect any organ in your body. So the commonest is fatigue and declining in the quality of life, muscular weakness, joint pain, dyspnea, cough, and so on and so forth. And so this study further evaluated about these post-COVID phases. It is contributing, it is discussing about 3 phases of post-COVID syndrome. The post-COVID phase 1, which is extending from 4 weeks to 12 weeks, acute post-COVID, and then long or chronic post-COVID leads to 24th week, that is usually 6 months, and 6 months onward, that is phase 3 or the persistent post-COVID syndrome. If you consider the post-COVID syndrome, and see during acute, the fatigue is one of the commonest symptoms. However, that even in the post-COVID follow-up, fatigue is the commonest syndrome and symptom. Actually, that about 60% of the patients, they have a post-COVID symptom of fatigue. And breathlessness is the second most commonest symptom in acute COVID, as well as you can see about 50% of the patients who have been discharged with COVID pneumonia complaining of breathlessness. So once these patients come to us, we evaluate these patients and we take a history and we do the basic evaluation, including lung functions, walk test, X-ray, as well as some of the syndromes. There are at least 3 pulmonary syndromes that we classify these patients into. The first syndrome is a post-COVID bronchial hyperreactivity syndrome, which is quite similar to asthma. The second one, or the most significant one, is the post-COVID ILD, which I'm going to discuss in detail, and then the post-COVID pulmonary hypertension. If you consider the post-COVID bronchial hyperreactivity syndrome, it is equivalent to asthma. Most of the patients will get breathlessness when they are exposed to cold or when they're having a cold bath, or it is with diurnal variation that is usually lasting for at least 3 weeks to 3 months. And this is a classical X-ray of a patient who presented with post-COVID bronchial hyperreactivity syndrome. As you can see here, the volume of the lung seems to be expanded, diaphragms are flat, and it is hyper, there's expansion of the lung. So this is a patient with a volume expansion or air trapping due to this post-COVID hyperreactivity syndrome. And most of the time, this patient will respond to short course of steroids along with dilators. And then not only this setup, but also there's because of this hyperinflammation, which is leading to uncontrolled symptoms of asthma and allergic rhinitis. Most of the time, we see patients who have been diagnosed with asthma or asthma COPD overlap or allergic rhinitis who has controlled symptoms and coming with uncontrolled features of asthma or uncontrolled features of allergic rhinitis, purely because of this hyperinflammation led to this of this asthma and allergic rhinitis. The post-COVID pulmonary hypertension, that is an evolving area actually, that there are several case reports published, as well as whether it's a sequelae of corona, and there's increasing amount of collecting, their data is collected about this patient who are having pulmonary hypertension. This could be pulmonary arterial hypertension, that is a group 1 pulmonary hypertension, or it could be group 3 because of the hypoxia due to lung fibrosis, or it could be even group 4 because of the chronic pulmonary embolism. However, this is an evolving area, and still we don't know fully about this post-COVID pulmonary hypertension, but it is going to be a significant a pulmonary syndrome that we are going to face with. So I'm focusing mainly about the post-COVID interstitial lung disease syndrome. Initially, there's significant, or there's quite a lot of argument between the academics whether this is resolving or remnants of changes that we see in pneumonia at the initial phase, or is this a separate entity? But we have this is a separate syndrome. There is evidence of persistent physiological impairment in this patient. That for that, if it is a pneumonia, if it is resolving a pneumonia, and there should not be physiological impairment in these patients. Now we know there's persistent physiological impairment. And then then there is evidence of persistent radiological abnormalities, disease of fibrosis. That is also unique, and some of the radiological changes are progressing irrespective of the resolution of the COVID pneumonia. And then there is evidence of biomarkers which are persistently positive in these patients, which are quite common, and we see these biomarkers in other patients with interstitial lung diseases or other cause of pulmonary fibrosis. And then there are shared genetic predisposition in these patients, 9 compared with the other patients with lung fibrosis. So there's a genetic predisposition and there's biomarker predisposition. There are persistent functional impairment as well as persistent radiological abnormalities. Therefore, we consider this post-COVID lung fibrosis as a separate syndrome itself. There is a study done by a team of researchers and published in International Journal of Medicine. And here, what they found, actually, they have done extensive physiological screening of patients following post-COVID after 2 to 3 months from their COVID pneumonia. So what they found, there's statistics, and also that there's a control arm. The patients with other viral pneumonias, predominantly patients with influenza, has been studied. So after 2 months, as you can see in lung functions, there's in COVID pneumonia, there's a significant restrictive abnormality compared to the pneumonia. Those are less common compared to the viral pneumonia, but there is significant. But diffusion capacity of carbon monoxide, or the diffusion capacity, is significantly higher in the patients with post-COVID lung disease compared to other viral pneumonia. So we know there's a predominant restrictive abnormality as well as a predominant diffusion abnormality in these patients. This again study done and published in Lancet 2021, which they have found. It is done in China, and as you can see here, the blue color is 6 months lung function impairment, and orange is a 12-month lung function impairment. As you can see here, there's persistent diffusion capacity abnormality, diffusion abnormality in these patients, and also that you can see the functional forced vital capacity also persistently impaired in these patients. This is a study again done by the same group in China, published in Lancet 2021, and this is again suggestive of persistent radiological abnormalities after 12 months and 6 months of severe COVID pneumonia. As you can see, some of the abnormalities like line and irregular lines and fibrotic areas, all these things are increasing compared to the 6 months. So the radiological changes are progressing more time. So this is a separate syndrome. And the biomarker study done again in China, as you can see, there are biomarkers of epithelial injury, biomarkers of epithelial injury fibrosis, as well as epithelial repair. All these biomarkers are significantly elevated in these patients with COVID pulmonary fibrosis, and these biomarkers are the same biomarkers that we see in patients with interstitial lung diseases due to other causes. The genes, this is surprising, this study. What we found actually 14 out of 15 genes associated with lung fibrosis due to other causes, predominantly IPF, has been associated with COVID-19 fibrosis. So these patients have a genetic similarity to the patients who are going into the lung fibrosis due to other causes. So therefore, now the global academia, we have developed a post-COVID ILD model. Now we know the patients who are developing lung fibrosis and who are developing post-COVID ILD. I'll discuss about this model. And so when the patient exposed to COVID-19 and there's a monocyte, macrophage, and lymphocyte activation, and if there is a genetic predisposition on these patients, particularly patients who are elderly, aging more than 60 years, and then when there's severe pneumonia involved, these patients are going into epithelial injury, and this epithelial and epithelial injury, which release cytokines, chemokines, immune and inflammatory cells, and certain group of patients go into activation and migration, proliferation of fibroblasts, and certain of patients actually they go into deposition of extracellular matrix, secretion, organization, and remodeling. So therefore, your prevention of post-COVID pulmonary fibrosis starts at the time of prevention of COVID itself, and then prevention of the inflammation or management at the pneumonia. So management of COVID pneumonia is significantly, it is really important to prevent your post-COVID lung fibrosis. So this is the stage. I mean, all your lockdown and all the other measures, the wearing mask and everything prevent you from getting COVID, and the vaccination also will prevent kind of your inflammatory response to a certain degree. But once you develop the pneumonia, and this is the stage that is hyperinflammation that you have to manage with the immune modulators. Remember, please do not introduce nosocomial infections by introducing inappropriate steroids, inappropriate immunomodulators, as well as inappropriate antibiotics at the early stage. And also prevent ventilator-induced lung injuries as much as possible, and also prevent dehydration on these patients. So therefore, remember to prevent post-COVID lung. It's only the immunomodulators that we should, the parameters, and we should care these patients, we should hydrate this patient, and we should avoid unnecessary treatments for this patient. By this model, now we know there are two phenotypes of post-COVID ILD. The first phenotype is the phenotype where there is increased deposition of extracellular matrix, secretion and organization and remodeling of this lung, that is known as early autoimmune ILD. One ILD phenotype. The other phenotype is actually activation, migration, proliferation of fibroblasts. That phenotype, that is the early fibrotic phenotype. So we have two phenotypes of ILD in these patients. So these are some of the expressions that presented to us, actually to Candy. The 74-year-old male who has diabetes, who's presented with MMRC3, breathlessness, for 4 weeks duration, and the patient gives a history of cough and upper respiratory symptoms about 8 weeks back, but not tested for COVID because the patient was vaccinated before, and the symptoms were spontaneous resolve. But the patient came about 8 weeks after to us with worsening shortness of breath of MMR C3. And here, what we see in this patient, what we saw in this patient. Here you can see there's increased amount of ground glass as well as constellations which are distributed around the bronchial vessels and around lobules of the pulmonary tree, and this is known as COVID organizing pneumonia. This patient was treated with steroids, and after about 2 months, about 6 to 8 weeks, with the second CT scan, you can see that it is almost resolved with residual changes. So this is the first phenotype I was talking about. And the second patient, actually 68-year-old lady with diabetes, present with severe COVID pneumonia, required non-invasive ventilation and persistent oxygen requirement. And following four weeks of initial presentation, we have done a CT scan. This initial CT scan actually shows again perilobular consolidation, suggestive of organizing pneumonia. And then the follow-up CT in about 4 to 8 weeks time showed areas of traction and fibrosis. So therefore, there are 2 post-COVID ILD phenotypes that we should recognize in these patients: the early autoimmune phenotype and the early fibrotic phenotype. The early autoimmune phenotype, basically, it is due to the immune inflammatory cascade. As you know, there's an evasion of the epithelial component, there's epithelial damage, and evasion of the endothelial component, there's endothelial damage. And these patients have abundant lymphocyte infiltrate, and if you do a bronchoalveolar lavage, they will show lymphocytosis, and in the radiology, they will show the organizing pneumonia-like pattern. And the treatment is immunomodulation. Basically, these patients are steroid responders, and they have excellent response to steroids. And most of these patients, actually, we see persistent, significant proportion of these patients have persistent ANA positivity. Remember, any viral infection can activate your ANA levels or ANA positivity, but these patients have a persistent ANA positivity, which if you do the test in 3 months, and they will have a positive ANA levels. And then the early fibrotic phenotype. That is usually, again, patients who are having pre-existing ILDs or pre-existing conditions which can promote ILD, for example, like who are smokers and elderly, especially men, and with exposure to various other inorganic or organic dust. So these patients, actually, once you get the COVID, they'll have post-COVID fibrotic patterns. And these patients, actually, if they are progressing, and we might have to consider these antifibrotic therapies. So what are the therapeutic implications by phenotyping post-COVID ILD? So for example, once you get a patient with post-COVID ILD, now we know they share common genes, and they share common biomarkers, and they share this common two-hit injury hypothesis that is known for other interstitial lung disease. So therefore, what I'm suggesting, and globally it is happening, and especially in Europe and UK, we should discuss this patient in an MPT, where the pulmonologist, radiologist, and as well as immunologist should come together and discuss these patients and reclassify these ILDs according to the current ILD classification. If the patient is having autoimmune, autoinflammatory type, remember our objective of treatment to achieve complete remission. We are not going to treat partially. Appropriate treatment, you know that systemic steroid dosing with gradual tailing off dosing can almost completely resolve these pneumonias or organizing pneumonias in early autoinflammatory type. But there's significant low proportion could go into fibrotic phase, but still majority, more than 90% of the time, if you treat appropriately with steroids, these patients can be cured completely. The second pattern, this is a study conducted in Italy. They have collected all the data of post-COVID ILDs, and they are phenotyped against this early autoimmune as well as early fibrotic phenotypes, and early fibrotic phenotypes has been reclassified according to the available ILD classification. There, they have identified about 11% of these patients are having fibrotic NSIP and OP. About 6% of the patients were indeterminate for UIP, and about 1% had definite UIP. And so these patients, actually, you might have to consider antifibrotic therapies early if the patients are actually progressing. Our objective of these patients to achieve independence from long-term oxygen therapy, as most of the patients on this fibrotic phase are having are on oxygen therapies, actually. So our aim is to make them independent from oxygen, and also at least achieve a partial remission to make their day-to-day activities and to achieve stability. So these patients, we don't have an indication to start antifibrotics early, and there are 4 trials at the moment answering this question, but at least if they're not responding to steroids, and you have to consider antifibrotics early in these patients. So with this, all the evidence, this is actually, we develop a model for managing these patients with post-COVID ILD. And this is, I mean, this has been not signed, I mean, studied it, but this is from overall evidence that what we gathered from the literature. So once a patient with post-COVID lung fibrosis comes to you, for example, a patient coming with breathlessness with after a COVID infection, you should evaluate this patient. You take a clinical, you should assess the patient clinically, ask about the patient's severity of symptoms and the COVID status in the past, as well as you have to ask about other risk factors for interstitial lung disease in these patients. For example, whether these patients are having any other autoimmune features like, you know, joint pains, as well as any dry eyes, dry mouth, Raynaud's phenomena, history of previous miscarriages, as well as exposure to various inorganic and organic deaths. So when a patient comes to with post-COVID breathlessness, you should take a detailed history about their breathlessness, their onset of symptoms, their severity, associated factors, worsening or aggravating factors, delaying factors, as well as other possible etiologies has to be evaluated. If there is any evidence of possible contributory factors other than COVID, you should screen these patients for the etiologies. For example, doing autoimmune antibody levels or ANA levels or rheumatoid factor and things like that are advisable if you are thinking there is a particular autoimmune or any other related exposure to this patient. And then describe the patient's HRCT pattern along with the functional assessment of lung functions, DLCO, as well as walk test. And please discuss with your radiologist or discuss with the immunologist and discuss with your pathologist and come to a diagnosis whether it is an early autoimmune pattern that we are seeing or whether it is an early fibrotic pattern that we are seeing. And then reclassify again with the current ILD classification. If it is early autoimmune disease, depending on severity, you might consider higher doses of systemic steroids. Usually we consider about 0.75 1 milligram per kg, or sometimes we might consider IV methylprednisolone. And then if it is early fibrotic, again, our treatment of choice is steroids initially, and then follow-up assessment in about 8 to 12 weeks time. And then if the patients are having persistent immune features in the CT scan, you might have to escalate immunosuppression. Remember, there are no evidence yet for this. We are collecting evidence, but still we don't have any kind of randomized controlled trials, because this is an area of evolution. So for various other immunosuppressants like mycophenolate and cyclophosphamide, things like that. But still, you might discuss about a possibility of adding these drugs at that point. And if the patient is going into the fibrotic phase, or the patient is having any evidence of progressive fibrosis in their lungs, that you might consider antifibrotic therapies at that stage for the early fibrotic pattern. And sometimes this autoimmune feature, autoimmune interstitial lung disease might shift to this fibrotic ILD pattern with the treatment in a small minority. At that point, you might consider. Remember, there's a single study published about antifibrotics in Japan. That study did not show significant benefit of starting this drug, but that is a single center observational study. But there are 4 randomized control studies are going on for the time being for antifibrotics. So I'm requesting you all, if you are considering, especially pulmonologists, if you are considering antifibrotics, please consider data collection of these patients, because we don't have any RCT evidence for this. So if I summarize my talk, it is important. COVID is not giving all the drugs at the same time. COVID success depending on identifying the right patient at the right time onset. For example, even if you consider antivirals like remdesivir, you have to give it early. If you're going to go tocilizumab, you have to get it early. And steroids, and the patient is hypoxic. So identify the patient correctly, identify the patient at the right time, and give the right treatment, and please give it for the right outcome. So this is the success story of COVID, and not giving all the drugs for all the patients. So I'd like to conclude my presentation here, and again, I thank for audience as well as the SLMA for inviting me for this topic. Thank you so much.